Okay, so here is a continuation of the high-risk newborn and birth trauma lecture. So this is part 2. We are going to continue from where we left off in part 1. So I believe this is where we left off, talking about non-nutritive sucking, and now we are going to talk about skincare for our preemies. And you can see this preemie, this is a very premature infant, probably like 26 weeks. 27 weeks, and you can see how thin their skin is. Their skin is so thin and it's so fragile. When I mean fragile, I mean we can actually just break and rip their layer of skin off. So it's very important that we are doing frequent skin assessments of them. Now, yes, they are not as heavy as an adult and prone to pressure ulcers like an adult, but they do have certain pressure points in their body, like the heel of their foot, their elbows, where they rub. So when they move, they rub against the linen, and that can cause breakdown. We have to be very careful about how we tape anything to their skin. So if they have an IV or they have an endotracheal tube, if they have IVs going through their umbilical cord, because there are vessels in there we can use as IVs. We have to be very careful and use the least amount of tape possible to keep it in place. The other thing we have to consider is how we take that tape off. We have to be very careful. We can't just rip that tape, because I have seen that done, and it will literally rip off the top layer of skin and then leave a wound or a sore. Okay, so it's very important. Repositioning these babies helps with that, the pressure on those points, so the elbows, the heels. We don't want to leave them on their abdomens too long because of pressure on their knees from moving their legs. And these babies don't need baths very often. I mean, every several days, if that, maybe once a week. They're not getting dirty. And when we give them a bath, we do not need to use soap, because it can just be harming to their skin and too rough. Okay, environmental concerns. Remember that I said these babies, the premature babies, should still be in mom's womb where it's quiet and it's dark and it's calm. And now they're born and they're out in the world, which is noisy, bright, cold. There's a lot of things going on, okay? And those environmental stimuli can interfere with their ability to stay calm and then do what they need to do as far as oxygenating, staying warm, digesting, and growing, okay? So the NICU, before there was research done, used to be a very loud place, very similar to your adult ICUs, where you just had a lot of noise going on. So NICUs have become very cognizant of their environment. So when you go into a NICU, it should be quieter. The nurses talk quieter. They shouldn't talk a lot at the infant's bedside if they're still very premature. We tend to keep the lights dim, especially during the night, to try to create that day-night environment, okay? There's things in the NICU that affect their sight. Almost every premature infant is going to be under the phototherapy lights, and we talked about how that can be damaging to their eyes, so it's very important that their eyes are protected. I talked about keeping the NICU darker during the night to help create that day-night routine. And there are common medications that preemies take, Lasix, because many times if they're severely ill, they retain fluid. Gentamicin is a very common antibiotic used for the newborn, for infections. Both of these medications can have adverse effects on the hearing system, so it's very important that they are given very slowly on an IV pump and only used when necessary. So in the NICU, it's important that we keep it dark, we keep it quiet, we keep it calm. Developmental care. Okay, what I mean by this is, once again, the premature infant is still supposed to be in utero. Mom is supposed to be keeping baby warm, keeping baby quiet, keeping baby in that fetal position so that all of those ligaments, muscles, joints can develop properly. Well, what's happened? Remember, the baby is born, and now the baby is out here in the world to do everything on their own. Your premature babies are very floppy, okay? And so they tend to just kind of lay out like this. But that's not good for their joints, for their muscles, for their ligaments. So positioning preemies in a enclosed or I'm forgetting the word, keeping them kind of in a fetal position is good for the development of their joints, their muscles, their ligaments. So you will see babies in the NICU where they have rolls that are used, different positioning devices to keep them in this enclosed central position, okay, for development of those joints, ligaments, muscles. We do put preemie infants in every position. We put them side lying. We actually put them prone on their abdomen. They like to be on their abdomen. It's okay for them to be on their abdomen because they are on the cardiac monitor in case anything started to happen. And putting them on their abdomen helps with oxygenation. If you think normally, like I just said, we like to keep them in this close position for their joints, but it kind of closes up their chest. So by putting them on their abdomen, we're opening up that chest area and helping respirations and oxygenation. So we rotate their position every 3 hours or whenever schedule they're on for their vital signs. And physical therapy is very common modality in the NICU. Most NICUs will have a physical therapist assigned to the NICU. They either just work in the NICU or they make rounds in the NICU, and they do physical therapy and range of motion with our preemies to help with their motor development. We talked about keeping the light and the noise down so we don't overstimulate these babies. Your babies will talk to you. You just have to know how to listen. And it's very important that we recognize when they are becoming stressed because there's too much going on around them. Because if they become too stressed, it's going to affect their physiologic being, and it could cause them to have respiratory symptoms and affect their oxygenation. It could cause them to have episodes of bradycardia. Okay, so how do we know that our baby is becoming anxious and tense? Their gaze is going to change. They're not going to be looking at you. They may show feeding difficulties such as gagging and spitting. Most commonly, they become tachycardic. Their respiratory rate becomes irregular. They become apneic or it becomes increased. And they just get tense, and you'll just see that they'll become this tense, extended baby. They're not in that comfortable position. And you can see if they're relaxed, we're going to have stable vital signs. They're going to stay in that relaxed, closed position, and they're going to keep their eyes closed because they're calm. It's important for the nurse to be able to recognize these and know when their baby is becoming anxious. It could be someone is doing physical therapy with them. Maybe the parents are in and they're touching their baby a lot, or they want to hold their baby and they're holding their baby and they're just stimulating them too much. If you see these signs of anxiety in your infant, it is okay to stop whatever is going on and say, you know what? This baby is not tolerating this activity right now, and this baby needs to just go back in the isolette or the radiant warmer and be left alone for a while. It is okay for you to advocate for your baby in that way. Also related to developmental care, how we can encourage and enhance development, because as the baby gets older, the baby is going to then respond differently to stimulation. So at the beginning, we try to eliminate stimulation by doing cluster care, which means that the baby is put on a schedule, maybe every 3 hours, every 2 hours. If they're getting close to going home and they're very stable, maybe every 4 hours. So what happens is then, let's say that baby is every 3 hours at 9 a.m., 12 p.m., 3 p.m., and so on. So if we're doing cluster care at 9 a.m. in the morning, we're going to go to that baby's bedside. We're going to do everything we need to do. We're going to do vital signs. We're going to do our assessment. We're going to change the baby's diaper, reposition the baby. If it's time for a feeding, give that feeding. And then what we're going to do is when we're done, we're going to leave that baby alone till the next 3-hour assessment is due. So at 12 o'clock. We're not going to touch that baby in between there unless that baby does or shows us something that means they need attention. Because we want them to just relax, okay, and be able to do what they need to do. Okay, so that's cluster care. Now, as the baby starts to age, then we're going to increase stimulation, having parents hold, rock the baby, talk to the baby, maybe play some music for the baby. But remember, you have to assess their state. Are they becoming anxious or are they still relaxed? So we kind of have to increase stimulation based on how the baby is reacting. Okay, and you can see here when I talked earlier about skin-to-skin contact, that is actually called kangaroo care, because it's kind of like putting the baby in a little pouch up against mom or dad. This is what it looks like. Okay, and it does all of those things, improves oxygenation, helps keep the baby warm, and of course helps with that bonding and attachment. Some other things that we need to pay attention to is how are the parents adapting to their baby in the NICU. Now remember, this was not the plan. The plan was that they were going to carry their baby to term, have a term baby, and go home in 2 or 3 days. And this is very different. One, depending on how preterm that baby is, they're going to go through this grief called anticipatory grief, where they're always thinking about how sick their baby is and really, is my baby going to survive? Because for many preemies who are born very premature, it really is a day-by-day situation. Babies can be okay one day, they can get very sick the next day. It varies. They will roller coaster throughout their stay in the hospital. And so parents are always thinking about, is my baby going to survive? Is my baby going to be okay? And they have to come with to terms that they have a premature baby and they did not get to the point of delivering a term baby and going home in a couple days. So it's very important that we help parents maneuver through this situation and help with the bonding and attachment. Sometimes their baby may only be stable enough for them to touch their baby, like in this picture here. They may not be able to hold their baby right away, okay? But we need to encourage bonding in any way we can. So it might just be touching their baby. It might be just talking to their baby so their baby can hear their voice. There are different support groups for the parents. Of course, they have their family. There are support groups specifically created for parents of premature infants. Some larger NICUs at bigger hospitals have those support groups in the hospital on the unit that meets on certain days of the month. Other family members of babies in the NICU become a support group because they see them every day and they may notice that, oh, that baby used to be as small as my baby. And so they talk to other parents and they support each other. The nurse becomes a big support system for those parents because the nurses are there with their babies 24 hours, 7 days a week. Parents have to go home at some point. They can't stay in the hospital 24 hours because it's going to affect their health, especially a brand new mom who is also healing from her delivery. Also, sometimes babies are in the NICU for months. We typically tell parents that their baby should be there till what would have been their due date. So if you have a baby born at 28 weeks, 24, 26, 27, they're there a long time. If they are working mothers, they may use up their maternity leave and have to go back to work before their baby comes home. So they will not get to visit. They trust you as the nurse to take care of their baby and to let them know how their baby is doing. They want to know that they can call in the middle of the night and ask how their baby's doing, and you'll be able to tell them. So you become a big support. I remember when I worked at Children's Memorial and I had a baby, her name was Caroline, baby Caroline, and she was in the hospital for, at least 3 months, maybe even 4 months. And I became very close to the parents because we did primary care nursing. So that meant that every day that I was on, since I was part of her team, I would take care of her because that provided consistency with the parents. And I remember when she went home, after that long stay, I received Christmas cards from her family with a picture of Caroline, letting me know how she was doing. And I received those cards for probably about 3 or 4 years. And so we became connected, and I was a support for them. One thing we have to make sure that we're looking for is how are the parents adapting? It is very easy for parents to not know how to adapt to this circumstance, how to interact with their sick newborn in the NICU. And so we have to make sure that we're assessing this, we're watching for this, that we are helping parents adapt properly. Because if they have not adapted to this, how to take care of their baby, if they haven't really bonded with their baby, then this does set this baby up for abuse when they go home, because the parents just don't have the coping skills to take care of their premature baby. There's a lot of discharge teaching that goes on with a preterm baby. Some babies will go home on oxygen, some babies will go home with NG tubes or G tubes or special medications. So it's important that we start day one when that baby is in the NICU and start teaching that mom and significant other, whoever is going to be caring for that baby, how to care for that baby once they go home. We cannot wait until the day before discharge to teach them all of these things if they are necessary. All right, so there are certain complications that our preemie babies are prone to because of the fact that they are premature. Remember I said that they don't start to develop and make their own surfactant till about 34 weeks of gestation. So if you have a baby born around 34 weeks or younger, they are at risk for respiratory distress syndrome. This is a temporary, usually non-life-threatening respiratory situation just because of the lack of surfactant. So many times these would be the babies that would receive artificial surfactant, okay? And then once they receive the surfactant and they're able to, their lungs can move better, they can oxygenate better, it resolves after a couple days. Symptoms that they have respiratory therapy would be symptoms we talked about before: grunting, an increased respiratory rate over 60 per minute, poor color because they're not oxygenating, retractions. You would see their skin get sucked in because they're just breathing heavily. You might hear crackles related to fluid in the lungs, and you would not hear good breath sounds. So typical treatment is O2 therapy. It might be an oxy hood, it might be nasal cannula, it might be nasal CPAP, but it usually does not go beyond that. Artificial surfactant, as I just mentioned, and then of course we're going to watch their O2 sats, and they would be on IV fluids. This baby would not be on oral feedings, probably maybe not even NG feedings at this point until the respiratory symptoms are resolved. Another common complication for our NICU babies is called necrotizing enterocolitis, often referred to as NEC. Okay, this affects the GI tract. It affects the tissue and the mucosa in the GI tract. It can be caused by lack of oxygen to that tissue. It can be caused by an infection in the GI tract. And basically what happens is tissue in the GI tract dies because of the infection or the lack of oxygenation. And so the tissue dies, and if we don't catch it soon enough, then that part of the bowel can actually perforate. Okay? And so it's very important that we are observing for symptoms and we recognize them early. Because many times if we recognize the symptoms early, then we can hopefully prevent it from getting to the point of perforating and that baby losing part of their bowel. I have seen babies with NEC lose a small part of their bowel and have the ends of the GI tract just stitched back together, reconnected, and do fine. I have had preemies in the NICU where they had to remove part of the bowel, and then in order for it to heal properly and rest, they ended up with a temporary colostomy. I have seen babies in the NICU where for some reason the NEC was not recognized soon enough, or it just sometimes will go from nothing to awful quickly. And I've seen babies lose 80%, 90% of their bowel and then end up what we call a short gut patient. And so you know that if you lose so much of your gut, it then affects nutrition and absorption. Okay, so it's important. The typical symptoms you will see at first is abdominal distension. Okay, they will have blood in their stools. So many times while preemies are in the NICU until they reach a certain age and are stable, we will do bedside tests of their stool for blood. Another common symptom is erythema of the abdomen, which means that their abdomen just changes color. It gets this purplish discoloration, and so that's a key symptom. As it progresses, they're not going to tolerate their feedings. They're going to start to vomit. We're going to see increased residuals, and as it further progresses and becomes worse, it's going to affect them overall physiologically. They're going to have periods of apnea, their heart rate's going to start to drop, and it's going to affect their oxygenation. So the treatment really depends on when we recognize what is going on. If we recognize it early, the first thing they will do is they will make that baby NPO, put the baby on antibiotics in case it's being caused by an infection, a bacteria, stop whatever formula or breast milk feedings they're on, and put them on IV nutrition. And then they will monitor and observe them. Many times it will resolve just through this GI rest and treatment with antibiotics. If it continues and becomes worse, or if it's bad right out of the bat, then they will take those babies to surgery, and as I said before, they may have to do a bowel resection. And sometimes they may just remove a little piece of bowel, or they may have to remove a lot, okay? So depending on the severity of the symptoms depends on the treatment. Typically, if we recognize it early, we just try to treat it with GI rest and antibiotics. Worst case scenario is surgery and a bowel resection. Okay, the other common complication that our preemie babies experience is called patent ductus arteriosus, or PDA. Now remember, we talked about fetal circulation. And remember what the ductus arteriosus does. It bypasses blood from the lungs because mom is oxygenating, okay? So what happens when the baby is born? They take their first breath, pressures change in the cardiac and respiratory system, and that ductus arteriosus clamps closed. And now all blood is going through the lungs for oxygenation. Well, sometimes with their preemies, when they take those first breaths, there's not enough of a pressure change and it doesn't close all the way. Or sometimes it closes at birth, but if the baby has a stressful event later after birth, it can reopen. Well, now what is the problem? Remember, now that baby is oxygenating on his or her own, all of the blood has to go through the lungs to receive oxygen. Well, if the ductus arteriosus is still open, then there is blood being bypassed, not going through the lungs, and going straight into central circulation without being reoxygenated. And so it affects the infant's oxygenation process. Depending on how much blood is being diverted from the lungs because of this patent ductus arteriosus will determine how bad oxygenation is being affected and what needs to be done. The most common symptom of a PDA is a murmur. So if you remember what a murmur is, it's a sound that is created because blood is flowing through an extra place, the ductus arteriosus. You may have changes in pulses, you may have increased heart rates, increased respirations, and you may hear crackles in the lungs because of fluid. Okay? Treatment. Treatment can be with medication. Indomethacin. Indomethacin is a medication that causes that ductus arteriosus to clamp close. So that's usually the first treatment that is tried. Depending on how much oxygenation is being affected, they may need some type of respiratory support with the indomethacin treatment. And if they are having backup of fluid into the lungs, then they may be on a fluid restriction. If the indomethacin does not work, it doesn't always work, and the PDA remains open after being given indomethacin, then they will need a surgical ligation, where they will make a small cut in the chest, go in, and tie off or tie closed the ductus arteriosus. Okay, now that's for your infant where the indomethacin doesn't work and they are having significant oxygenation symptoms or issues. Okay, pain. Do you think babies feel pain? I hope you all said yes, because they do feel pain. And yes, they can tell us that they're in pain. We just have to know how to assess that. Okay? We can assess their pain through their physiologic and their behavior characteristics or changes in those characteristics. Because they can't actually speak and tell us they're in pain, there are assessment tools that have been created to assess infants' pain, and it's basically looking at their physiologic characteristics and their behaviors. And are there changes in place that indicate they're in pain? Okay? Babies do remember pain. They remember it a little different than we do. They may not remember what caused that pain, and they may not remember it when they're older, but they do remember pain as an infant. So if you have a premature infant in the NICU who is getting a lot of heel sticks for lab draws or peripheral blood gases or for glucose levels, later on, after we're even done doing those procedures, let's say weeks down the way or even months down the way, if you go to touch that infant's foot, they may draw their foot back from you because they associate that touch, that part of the body, with pain. So they do experience pain and they do remember pain. So it's very important that we are monitoring our baby's pain levels and assessing for pain and treating pain. Okay, so symptoms of an infant in pain. They're going to cry. They may become tense, okay, rigid. We're going to see changes in their vital signs. So heart rate is going to increase above normal, or maybe increase from their norm. Their blood pressure will increase. Their O2 saturations may decrease if they're in severe pain, okay? So we need to make sure that we're watching for those. Non-pharmacological pain management, holding them, swaddling them, giving that pacifier for non-nutritive sucking. Music, a sweetie. A sweetie is a little kind of plastic thing that has glucose sugar in it. Glucose sugar has been shown by research to help infants deal with pain. And so they will give them a dose of glucose solution, which is called a sweetie. If their pain is so severe, let's say they had surgery, because there are conditions where newborns do have surgery, then we can actually use medications, morphine, fentanyl. We can give those in doses appropriate to the infant to manage their pain. So it's very important that we are assessing their pain, anticipating and treating their pain just like we should be for our adult patients. All right, I mentioned discharge planning, discharge teaching. Discharge teaching needs to be started from the day they come into the NICU. They may go home with medications. They may go home with feeding tubes. They may go home on an apnea monitor if they're still having periods of apnea. Depending on how long they are in the NICU, they will have started immunizations, so we need to make sure that mom knows which immunizations have been given, which ones are needed. Hearing evaluation, was that done? Did they have their metabolic screening? Do they need any referrals for in-home help with the care of their babies? And then typically every NICU has a policy that any baby under so many weeks gestation, those parents need CPR training before they go home. So the key is, you don't have to remember all of these, but you need to remember that discharge teaching is an ongoing process from the first day that they are admitted to the NICU until they go home. Okay? Whoops. Okay, now we're going to talk about our big babies. Remember when we talked about gestational diabetes, and we talked about sometimes those babies are big. Sometimes women just have big babies, okay? The problem with a big baby is it can make a vaginal delivery difficult. It can make it very traumatic for the infant, along with mom. And it can cause injuries to the infant because of their size and the difficulty of the delivery. The first one we're going to talk about is a fractured clavicle. So this is an actual skeletal injury where the clavicle either breaks while the infant is maneuvering through the pelvis, typically under the symphysis pubis, or sometimes large babies get stuck there and they can't maneuver under the symphysis pubis. And sometimes the physician may actually have to go in with their hand and break the clavicle so that it just kind of collapses and the baby can then deliver. So it can happen on its own or it can be intentional. And it's typically caused when those babies are so big and their shoulders are so broad and they get stuck in the pelvis. How do we know that a baby has a fractured clavicle? If it happens spontaneously during delivery, they typically will not move that arm where that clavicle is broken. So if it's my left clavicle that's broken, that arm typically just lays there by the side of the baby. They don't lift it. If we do the Moro, remember they're supposed to do this. Well, they're just going to do this. Whoops, wrong one. Only one arm is going to come up because the other arm doesn't move. You will feel crepitus at the site of that shoulder break or fractured clavicle. Remember what crepitus is? It's where there's little air bubbles that develop in the subcutaneous tissue related to the break. Sometimes we describe it as Rice Krispie under there. So anytime you have a large baby, over 8.5 pounds, a macrosomic baby, you need to make sure that you are watching, assessing their shoulders, their clavicles, and watching their arms for symmetrical movement, okay? Especially if labor and delivery said it was a difficult delivery. So treatment is fairly simple. They will recover on their own with just careful handling, keeping that arm immobilized, just like an adult who has a fractured clavicle. We want to put that arm across their body and keep it that way. Now, for an adult, we can put it in a sling. We don't have little baby slings. So many times we just create a sling with the t-shirt. So we would put the arm in the t-shirt over this and pin the edge of the t-shirt to, or the sleeve to the t-shirt, so it keeps the arm in this position, okay? We want to put some type of little sign on the crib so that people know that this baby needs to be handled carefully because of the fracture. Now, babies also do have HIPAA, so we can't just put a sign on the crib that says, I have a fractured clavicle, please be careful. So we typically have these little signs where we can just say, please handle me gently. And then everybody who would have any interaction with that infant would know that that means something. And if they don't know already that that baby has a fractured clavicle, they at least know that that means I need to go ask the nurse what's going on, okay? And then it will resolve on its own in just a couple weeks. Oops, did I go away? Okay, fractured clavicle, sorry. All right. The other injury that can occur to the shoulders, when we have a large baby, that it's the same setup as the fractured clavicle. Okay, the baby's broad, the baby's big, the baby has trouble maneuvering under the symphysis pubis and getting out. Now, this is not a skeletal injury, it's an injury to the nerves, because what happens is when the baby's trying to come under, and if the physician is pulling on the baby, there's a lot of pressure and tugging and just trauma to these Erb's Duchenne, the nerves that run here. So it's called Erb's Duchenne palsy. And so basically what happens is there's trauma to the nerves in the shoulder area. There's inflammation to the nerves. Now remember, the nerves are deep. We can't see the nerves. If there's inflammation to the nerves, that does not mean the shoulder is going to be swollen, okay, because it's at the nerve level. But this inflammation and trauma to the nerves affects the movement of the arm. So once again, if you have an Erb's palsy where you have damage to the nerve because of the traumatic delivery, that arm is going to hang at the side of the baby and they're not going to move it. Okay? The other key sign of an Erb's palsy is you can see that the arm is abducted and turned in like this. Okay? See how it's turned in? That's a key symptom. So, treatment. Once again, handle these babies carefully. This baby is not going to go in a sling. We're not going to position that arm because it's not a fracture of a bone. Oh, well, we are going to immobilize it in a certain, but we may not. We may just do it with swaddling. Sorry, completely. I didn't mean to say, oh, like I didn't know what I was talking about. Oh, you guys know me by now. It will be immobilized. It just might not be immobilized the same way because it's not a fracture of the bone. It doesn't necessarily have to stay in one place continuously. So we won't create a sling with the t-shirt, but we may just kind of position it and then swaddle the baby. And then once the swelling, usually after about 5 days, swelling goes down, the trauma goes down, and the baby starts to move the arm, then they may start range of motion exercises and getting that arm moving the way that it should be moving. Okay. Now this can be a temporary condition, which most times it is. Sometimes if the trauma was so severe, it could be permanent. Okay, the last thing we're going to talk about is our facial paralysis that can happen if a forceps is used for delivery of a large baby. Now, we talked about the forceps, and this picture shows where that forceps grabs the baby to help pull them out. And unfortunately, the facial nerve runs here. So it can cause, just like the Erb's palsy, it can cause edema and trauma to that facial nerve. And it can be a temporary condition, or sometimes it is permanent. So how do we know we have a facial paralysis going on? Both sides of the face do not move the same. Okay? The side of the face that is affected, the eye remains open because it affects the ability to blink. The mouth, you notice this baby is probably trying to fuss or cry. This side doesn't move. You can see how this side of the mouth is opening and this side isn't. Okay? There is nothing we can do for this. We just have to hope that as time goes by, in a few days, a week, that trauma to the nerve resolves, and that then they will be able to move both sides of their face the same. So many times this is temporary. Every now and then, if the trauma was too severe to the nerve, it can be permanent. Okay? All right. On the next exam, you are going to have a very specific math question about giving surfactant. Okay? And so surfactant is based on their kilogram weight. So you will need to use their kilogram weight to calculate the dose. So the order is 100 milligrams per kilogram. Given, you know what, I'm going to stop and I'm going to do this math question in a separate video. Okay? But what I do want to show you is I have posted a video on Blackboard that shows the journey of an infant born very premature, and it shows that baby's journey actually through the NICU and up to his first birthday. And I really would encourage you to watch it. It's only, I think, 6 or 7 minutes long, but it shows a lot of the things that we talked about in this lecture for our premature babies. Okay, that's the end of the lecture. I will then create another little short video for the math problem.